Hi, everybody. Welcome back again to the Get Healthy Tampa Bay podcast. I'm your host, Dr. Carrie Reller, and we have our expert vascular and general surgeon, Dr. Jenna Kazil, back with us today to discuss hernias. And since we just had a recent episode with you, I think we'll save that introduction for next time. But why don't you tell us, what are hernias, and let's just start with it.
So hernias are typically a break in the fascia, which is the connective tissue of our abdominal wall. And you can have those in any number of places. There's also something called an internal hernia, like a hiatal hernia, where you have essentially things that aren't where they belong, that can get stuck in different places due to a laxity in tissue. But the hernias we're talking about today are going to be abdominal wall hernias. So that's everything from inguinal hernias, ventral hernias, incisional hernias, things like that.
Okay. And so what are some signs and symptoms that someone might think that they have something wrong and it could be pointing toward a hernia?
The most common one is going to be a bulge. So, especially in men, they're going to have a bulge in their groin, usually right near their testicle or the base of their penis. And it's going to be, usually it's pretty painful. And over time, it gets bigger. Sometimes it's not painful, but it gets bigger and bigger and bigger. Usually you can push it back. In women, you can have just some groin pain. You can have a large bulge as well. You can also have an umbilical hernia. So people say they've had an innie for their entire life, and now all of a sudden they have an outie. And a lot of times I can very easily palpate that they have a fascial defect there from a small hernia. The other type would be a ventral hernia. So anywhere in your abdominal wall, anywhere along your abdominal muscles, you can have this bulge or pain, and that can be a hernia as well. And then finally, we talk about incisional hernias. So maybe you had your appendix out when you were a kid, or you had a gallbladder surgery, and now under one of your incisions, you have a bulging or painful area.
So why men more than women for the inguinal hernia?
So that has to do with really how we're all created in utero. So the testicles start as an intra-abdominal organ, and then over time, before babies are born, they proceed to the outside world and end up in the scrotum. And so you form this tract, and that can stay open, and that would be a patent processus vaginalis. And so this area is a little weaker and tends to form hernias more so than women, which, our ovaries stay within our bodies our entire lives.
So what are the signs and symptoms of having a hernia?
Pain, bulging, those are the big ones. Sometimes patients will actually have parts of their bladder or even their colon stuck inside their hernia. And so then they'll get problems urinating, or they'll have problems going to the bathroom in general. And those are usually much larger, more symptomatic patients.
Mm-hmm. And so so the hernia you said is like the breakdown of the fascia, but there's usually
Mhm.
an outpouching of, abdominal contents is what we're talking about is for like the risk factor of having
Yes,
more pain, right? Okay.
that's the hernia sac.
Okay. And how is it typically caused? Like what causes the hernia to develop?
It can be, again, I think there is a genetic component to this. And sometimes patients will say, yeah, all of my siblings have had hernia repairs. My parents had hernia repairs. You have a collagen defect. So an Ehlers-Danlos kind of thing, which is obviously much less common. But a lot of it is lifestyle, or you say you're a construction worker or you're a weightlifter, things like that may put you at more risk as well. So sudden heavy bouts of intra-abdominal pressure can cause the hernias.
And well, how do you kind of diagnose it or how does that, what's this?
So for me, typically I'm looking at the patient. And if I can look at a patient and see a bulge or feel a bulge, I'll actually put my fingers into the inguinal canal and feel this bulging sensation or a loosened area. And if I can feel that, I don't really need anything else. Sometimes, especially with incisional hernias, you can't really tell how big it is, or you think it's a particular size, but it makes it more challenging. And I'll get a CAT scan, and that's going to show me exactly where the fascial defects are.
Is there any imaging to do for the inguinal hernia or just clinical?
Only if you can't tell. If I can tell and I know exactly what it is, I don't get any imaging. Sometimes, from a diagnostic perspective, patients will come in and they'll say, well, I had an ultrasound. The ultrasounds to me are very tech dependent, and I really want to see those images. And I feel like if you're going to get an imaging, I'd rather just get a CAT scan.
Okay. So patient comes in, they're having like pain and bulging in there, and you mentioned the risk factors for more serious thing is, how about like, is there a concern for bowel obstruction or anything like that?
There can be. So, if you can push them back, and I'd say the majority I can push back, that's called a reducible hernia. I'm really not worried. And those need to be fixed, if they're bothersome, soon. Now, soon could be a couple weeks. I could say, well, you really need to see your cardiologist because you've had heart stents, and we really need to make sure that you're healthy enough to do any sort of procedure. That might be a month or two. But if they're stuck or if they can't go to the bathroom, then that becomes a much more concerning problem. And certainly if they can't go to the bathroom and they're completely obstructed, which would mean they're not passing gas, they're not having bowel movements, they might even be throwing up. Now that's an emergency where that patient's going to go to the emergency room, and then we're going to take them immediately to surgery.
Yeah, so you've got emergency surgery, and then I'm assuming, the rest of them could be more elective decisions.
For sure. And some patients have really tiny hernias. And a lot of times I'll see these patients and they come in and they have, a less than 1 centimeter, so less than half an inch belly button hernia that their primary care doctor found them. They have zero pain and they're freaking out. I'm like, well, what's going to happen? And I need this fixed right this minute. I'm like, well, actually, if you have zero pain and it's very small, you don't need to do anything. The VA actually did a great study on thousands and thousands of patients with small inguinal hernias. And so, when we say small, we're kind of talking about two different things. So first you have the defect in the abdominal wall itself, and then you have the size of the hernia sac. And what I think some patients and even primary doctors get confused is they'll say, well, it's a really large hernia. So the defect may be very small and the sac might be super large. And that doesn't mean that it's a large hernia. It might be very symptomatic, but the hernia defect itself is quite small. And the smaller the defect with the larger the sac, in my opinion, makes the procedure much more challenging and is more likely to incarcerate. When you have these patients that have these very large hernia defects and very large sacs, things can freely go back and forth. It's much less dangerous. But the VA did a study and had these patients with small hernias. And after a year or two, the patients who had surgery didn't have surgery, had the same amount of pain. They were relatively asymptomatic, but most of my patients that I see over time, they get progressively worse. They get a larger hernia and they end up needing a procedure. So I may not do the patient. I may see them, let's say I see them today. Yeah, I did have some pain. The pain got better. Do I have to have it? And I go, no, you don't have to have it right now. And I'll see them back in 6 months. And I'm like, well, actually it's gotten bigger and it's more painful and I want it fixed. And that's fine. These typically aren't emergency procedures.
So how do you know what the sac size is and the defect size is prior to actually doing its procedure?
Sometimes you don't. Sometimes you have no idea. Sometimes you can see it on CAT scan. Most of this is all by physical exam. So I can tell just putting my fingers in the inguinal canal how large that is.
So what are the ways that you can operate and fix the hernias? What are the different ways?
So typically people will do this open. So they'll make a cut into the abdomen or into the groin somewhere. And for instance, for inguinal hernias, you're cutting out the sac and sewing that up. And that, a long time ago, 75 years ago, that was it. That was the repair. You would cut out the sac, you'd put some sutures in, you would try to sort of over sew some of the muscles and call it a day. And those don't work that great. There are still some people who do these over sewing types of repairs. And I think that there's indications, but you really need to talk to your surgeon about why you would do that. I think now, for the most part, the gold standard is going to be a mesh repair for any hernias, certainly any ventral hernias. So any abdominal wall hernias more than 2 centimeters. And I'd say for most inguinal hernias, people are using meshes as well. So the way that I love to fix these is on the robot. And there's a couple different reasons why I like to do the robot. For inguinals, there's really 3 different sites. And the inguinal canal anatomy is really extremely detailed and complex. But if you think about it like a triangle, so here's our triangle, and we have direct, indirect, and femoral components. And so what I can do is I can pull all of that hernia sac back into the body, and then lay a mesh over the entire triangle. And so now that area is no longer going to form hernia because it's covered with the mesh. And that's really my favorite reason to do it that way. The other reasons why I think are great on the robot, one, you can tell for sure. You can put a camera in there and you can see, is this really a hernia or not? Because you can see the outpouching and the defect. but also the decrease in pain and the improved recovery time. So typically for an open inguinal hernia repair, they might have an incision that's, anywhere from 3 to 5 inches, and they're going to be in pain and have kind of, a hard time walking sometimes. They're going to need some narcotics usually, and they're going to have that for 2 to 6 weeks of kind of just being sore. Not the end of the world, but patients don't really like that. Whereas my robotic patients are only sore for a couple days. I don't give any narcotics, and they're usually back to doing normal activities, even things like the gym and things like that, anywhere from 2 to 4 weeks, depending on what I'm fixing. That's for inguinals. Ventrals, I usually make them wait a little bit longer.
So the robot definitely has better recovery time, which is
100%,
important.
100%. The robot can be kind of challenging for incisional hernias because with incisional hernias, typically things are getting stuck in there, everything's really sticky, and that can be a little more challenging depending on what's going on. And sometimes I'll just say, this isn't the best option for this patient once I get in there and I have to convert to open, and there's nothing wrong with that. But especially these, smaller ventral hernias or an umbilical hernia that's maybe 3 or 4 centimeters, that's a great case for the robot. I think you get a really great repair. It looks really pretty. On the outside, you can recreate somebody's belly button. And I think it's a really great way to do it.
Do adhesions from prior surgeries make things more complicated when doing
Yes, it can. And sometimes you get these really filmy, they almost look like cellophane-like adhesions. And sometimes everything is just so gosh darn stuck, you can't see a darn thing. And that becomes a problem, especially when there's bowel that's trapped there, because then you can have a bowel injury, which can lead to an infection and things like that.
But in general, hernia repair is pretty safe.
Especially, a first time hernia repair, yes, they're usually very safe. Things that we think about, especially more so for inguinal hernia repairs in men, are potentially problems having children in the future or chronic groin or testicular pain. And the reason for that, again, is that the testicles go from the inside to the outside, and there's tubes that are connecting them. And so those need to be protected throughout the procedure, whether that's done open or robotically.
So I feel like meshes sometimes get a little controversy. Can you comment on that?
So the meshes that we used really 10, 15 years ago are no longer what I think most people are using. And a lot of those meshes got infected or they weren't the right type of mesh. Now people are typically using a polypropylene or a polyester mesh where it's sort of woven and almost loose, and that gives your body something to grow into. There are surgeons that are doing things without mesh, but I think the mesh we use for the most part is very, very safe with a very low risk of infection. I think what we were doing before, we had to learn that maybe that wasn't the best idea at the time, but no one was doing that on purpose. It was just a matter of, this is what we had, and we thought this was a great idea, and it didn't work well. So when we talk about fixing umbilical hernias, and people will say, well, we're going to use a mesh, or we're not going to use a mesh, and here's why I would or would not. Yes, it becomes very controversial. Most people would say that anything more than 2 centimeters needs a mesh. Now, typically that's going to be a mesh that doesn't go away. Sometimes, let's say I took out somebody's gallbladder and they had a hernia, and maybe one of the ports went through the hernia site because that was just an easier way to access, and I want to put a mesh in there. I might put a mesh that's going to dissolve over, say, 6 months, and that might be a safer way to go. And for a lot of my young patients with small hernias that don't want a long-term mesh, I think that's a great option.
Do you see any like allergy type reactions to meshes?
That's pretty rare because you're using essentially nylon or polyester. And so it's not like the, nickel or cadmium or things like that that patients tend to get allergies to. So not for the most part, but anything's possible.
Okay. So we talked about, the treatment and everything, but how do you prevent getting hernias?
So I think having a strong core in general is a great way to prevent hernias, but you have to be careful about the types of procedures that you do, or sorry, the types of exercises that you do. So when I see people doing sit-ups and things like that, you can pull your rectus muscle apart, and you really want to work on the inner core muscles. And so I probably see one patient a week who comes in with a diastasis, which is where the rectus abdominis muscles want to be kind of like this. Those are your six-pack abs. And they end up kind of getting more like this. And so this middle part here looks like a bulge, but there's no defect in the fascia. And it's actually a diastasis. And in order to fix that, you need to strengthen the muscles behind your rectus abdominis muscles to kind of pull those back together.
I was going to bring up the diastasis recti, especially after pregnancy. This
Oh,
typically
yeah.
is not something that you repair, is what you're saying, right? You just.
So typically it's not something that I would repair. I've certainly heard of people having a surgical repair of those muscles. I think that that's very challenging. And I personally encourage my patients to do physical therapy and exercises before considering that, because I think that I just think it's very challenging and very painful. And I don't know you're going to have the best results long term.
Mm-hmm. So you're saying focus on the core. How does that work? I know the core goes down further, but like in the inguinal area, like is that still strengthening the core area, or what is the?
You know, it's because of inguinal canal hernia, inguinal canal anatomy. I think that's very challenging. And there's not, in my opinion, a lot of exercises you can really do to strengthen that, because there's a defect to sort of start with. But having overall stronger abdominal muscles where they can sort of take that heavier load of day-to-day life is very helpful.
So that's what, to do, but how about what not to do for?
And so it's really not lifting things appropriately. So you don't want to increase your intra-abdominal pressure. So things like holding your breath when you're lifting things, chronic constipation, lots of pushing. You want to make sure that when you lift things or carry objects, you're doing them in a way where you're not going to hurt yourself and not causing undue intra-abdominal pressure. So breathing while you're moving or lifting things is super helpful.
The breath work when lifting is important, right? I think people get overlooked.
Absolutely.
And it's a similar thing for, I was going to say, like incontinence for women, right? You're going to be lifting things appropriately because you can be weakening the pelvic floor muscles as well.
Yes.
Awesome. Well, is there anything that we missed on hernias?
No, I think that's the majority of them.
Awesome. Well, this was so enlightening. And I know you briefly mentioned that like a hiatal hernia or internal hernia, was on the discussion today, but that's, a totally different thing that you don't do.
Correct.
But if patients, want to seek out to you for the other types of hernias, where can they find you?
So they can find me online at floridasurgicalclinic.com. And my office number is 727-surgery, which is 727-787-4379. And I have offices in Bradenton and Sun City.
Awesome. Well, thank you so much for being on the podcast again. This was awesome. I keep learning more and more from you, so I appreciate it. I'm going to have to start giving CME for these. It's fantastic. But all right, everybody have a good day and tune in next week. Thank you, Dr. Kate.
Thank you so much.